Hello, good evening, good day, good afternoon, or good morning, wherever you are in the world, and welcome to this special presentation sponsored by BD, looking at the modern challenges of postoperative wound care, especially in the COVID era. My name is David O'Regan. I'm a cardiac surgeon, and I'm also work with BD on their postoperative clinical complications program, and I'm sponsored to host this event. And I'm delighted to be joined by my colleagues in London. I reflect that the Society of Cardiothoracic Surgeons introduced surgeon-specific data regarding mortality. And at the time, it caused a great deal of consternation. Yet, despite this, year on year, the Society has seen a significant reduction in mortality for elective cardiac surgery. And in England and the United Kingdom, the mortality for elective cardiac surgery is between 0.8 and 1%. It is at a level now that it is safer having heart surgery than most other major surgery that we wouldn't even consider carries any mortality. So it's only pertinent that we now come to focus on wound infection. The shroud wavers would say that we have not seen any new antibiotics for over 10 years. And what with mutant strains, within 10 years, they would say taking elective surgery will be like taking your life in your hands. And this is rather dramatic when you think that most wound infections could be prevented. As far as I'm concerned, the idea of mortality and surgery, having been a patient myself or with a threat of surgery, didn't bother me. But really what bothered me was wound infection. The misery, the pain, the prolonged stay, and the cost caused by wound infection is immense. So the question is, what can we do to reduce wound infection? Well, the answer is there's no simple intervention. And wound infection is only reduced by addressing everything from the preoperative period, operative period, and postoperative period. It comes with attention to detail and a restless discontent for the status quo. Now, I was challenged by a trainee in 2009 who told me off in no uncertain terms for using bone wax on the sternum. Why? I had always used bone wax on the sternum. That's the way I had always done things around here. But an orthopedic surgeon wouldn't put bone wax as they plated a fracture. So Chris and I sat down, we put together a bundle that we believed would optimize the tissue healing and respect the tissue. And 1,700 cases later, collecting all wound problems, the median fell to 0. The funny thing is that despite us writing this up and having two categories of pre-bundle and post-bundle being very significant as P less than 0.005, when we actually got statisticians to look at it and compare that with colleagues, it wasn't a significant jump because at the time we also introduced a new antibiotic policy and we were attending to hand washing as well. Every patient deserves a wound like that. On the left is 2 days post-op, and on the right is that follow-up clinic. So my challenge to the society and challenge to you is, have we got the courage to adopt a standard operating protocol using the best evidence to open and close chests, to minimize what is essentially a preventable problem. And instead of having mortality-specific data, maybe we should have SSIs, surgeon-specific infection data. So my next challenge to the society and challenge to you is, who has the lowest wound infection in the society? What are they doing and why? And this is the principles of positive deviance that was first described by epidemiologists looking at failure to thrive amongst babies in Vietnam. And they couldn't figure out what it was, why some babies in one village did extremely well, and in the same village, other babies didn't do so well, and spent many, many months observing it, until one epidemiologist, following a mother into the rice paddy fields, noticed that she was putting grubs into the rice. The protein and the extra nutrition was surreptitiously being added by the mothers who cared for the babies. So tonight, we are joined by colleagues and experts who are going to tell us their journey in wound infection. And it's a privilege to actually introduce a colleague, Mr. Alex Cipollini, a consultant cardiac surgeon at Barts in London, who is the lead for infection control. Alex, over to you. Thank you.
David, thank you very much for your kind introduction. As David said, I am a consultant surgeon at Barts Heart Centre. And if I can cover my slides from the beginning, please. Thank you. If you go to the next slide, please. The Barts Heart Centre was really formed in 2015 when 3 hospitals, cardiac units in northeast London merged into one. So we called it the big merger. And we became one of the biggest cardiothoracic centres in the UK as a consequence. Next slide, please. The 3 hospitals, the original Barts Cardiac Centre, the London Chest Hospital from the East End, where I used to spend most of my formative years and was an early appointed consultant, and the Heart Hospital, which is part of UCH. Next slide, please. The interesting thing is even though we're about 3 miles apart, as soon as we told everyone we're going to merge into one site, 40% of the staff, which were currently employed on the 3 separate sites, decided to leave for various reasons. Too far to go, too expensive, or it takes too long to get there. So we lost 40% of staff, and we had to have some rapid recruitment of new personnel. Next slide, please. As we all joined, we suddenly realized that everyone has their way of doing things, and there was no common ground. All the legacy practices were introduced from 3 different departments, and there was no common ground, which made it quite difficult to act in this environment. Next, please. We found in the brand new building, which looked very nice and well designed, that we could not communicate. The reason why we could not communicate is because our phones didn't work inside the building. So if you want to find out where your patient has gone to, when you have 3 ITU options or 4 ward settings, you can't really find out where the patient is. So follow-up of patients and communication with your colleagues and the rest of the nursing staff became very challenging. Next slide, please. In addition to that, we found there were some environmental factors. Even though it was a brand new hospital, the incumbent team, given the task of cleaning the environment, wasn't performing to the levels we expected to. And we also found that in the theatre setting, literally opposite the theatre door, there's a toilet. And people used to use those toilets before they went to theatre, which we felt was inappropriate. So we had to change that. Next slide, please. As a consequence of all this, it's very quickly apparent that our infection rates, which were pretty good before we merged, suddenly became very high in this new environment. Next slide, please. And we've always engaged with publishing our results at the national level, and we engaged with Public Health England. And our results in 2016 were really astonishingly high, and we're outside what the PHE committees will say. We're outside of the normal expected guidelines, and therefore we had a letter saying we're too high and what's going on? Can we please address the problem? Just to give you a very figures you can see on the chart, the area in yellow is in-hospital infections. The area in white is patients who've come back with a wound problem. And the green area is patients who are in the community who we've found have had wound complications by telephone consultations or by GP letters. Next slide, please. We had to change our game. We had to improve, and we had to make a decision on how to do this. I've always had an interest in wound infections and how to reduce them, and in combination with a very proactive microbiology team, senior nurses, our surgical care practitioner team, who are very much involved in wound management, we formed a multidisciplinary team to address all the points which we felt were causing our results to be so high. Next slide, please. The one thing we had from the legacy hospitals, from the London Chest, we had a wound clinic which was run by the SCPs. And the wound clinic allows us to take charge of our wounds, to allow us to send the patients home with us vacuum-assisted dressings, and then bring them back to review the wounds, which actually allows us to send our patients home earlier than we normally would have done otherwise, which in the eyes of the management was a very good saving, which we can achieve in terms of hospital stay. So we reintroduced the wound clinic to everyone, and we had the wound clinic run exclusively by surgical care practitioners who very quickly learned how to manage these wounds effectively. Next slide, please. In addition to that, from the legacy hospitals, we had a whole variety of antibiotic prophylaxis. There was no common policy. Everyone did what they used to do 20 years ago. And based on our results, on our microbiology results and data, we managed to, at long last, within 2 years, rationalize and standardize the antibiotic policy for the unit. That took a little while. Next result, please. Next slide. Preparing the skin, I think, is really important in when you're going to do a clean operation, like anything inside the chest. And again, we had a variety of options available from different institutions, and everyone had their personal favorite. But based on clinical evidence, we all recognize that using chlorhexidine in alcohol at 2% is probably the best option available. In addition to that, we offered a surgical scrub wash to the patients who are elective patients to wash themselves for 3 days beforehand, before they come to hospital. And we continue with the same wash for the following 2 days after their surgery. The good thing about the surgical skin prep was that it has obviously a very effective antimicrobial effect, but also because you have a sponge on the end of your applicator, there's some degree of dermabrasion, which allows good penetration to the dermis of the skin of the chlorhexidine, which gives you a longer effect as antiseptic on the skin for a few hours or maybe a couple of days after the operation. Next slide, please. I think closing the wound in a nice, tight skin closure is essential. It's not always the case. And we did, again, use evidence on published papers and discussions with other companies about possible wound dressings. And we recognize that in certain patients who may be at high risk, a vacuum-assisted drainage of the wound in various guises can be very effective in reducing the infection rates. Next slide, please. Minimally invasive surgery is is coming into being with cardiothoracic surgery now, and we introduced endoscopic vein harvesting in the London chest before the merger. And we've now trained our entire SCP team to be proficient in using the endoscopic vein harvesting techniques. And we do, over 80% of our patients now have EVH. Very quickly, we realized that a high percentage of our wound complications were due to leg infections. And having started EVH, this was reduced significantly. Next slide, please. We had to work out who do we think is at high risk of getting a wound infection. Publications are limited. There's a paper published from the Brompton group about 15 years ago, which had a series of risk factors which increase wound infections. And we partly adopted that, but more to the point, we also looked at our patients and we did some regression analysis, and we see which patients are more likely to get a wound infection. So we devised our Barts Heart Center SSI risk scoring for our patients. The thing to mention here, our patients are slightly different to maybe other institutions in London. We have a very diverse population. We have a relatively low socioeconomic class, and poverty is quite high in the area we cover. A lot of our patients have diabetes. A lot of our patients are anemic. A lot of our patients live in overcrowded housing. So I think our patients may represent a slightly higher risk group. I think our SSI scoring system reflected that. Next slide, please. And the most important thing we've realized that we have to keep checking up on where we are at the moment, what has interventions achieved. If they haven't achieved the desired level, do we need to change them and rediscuss them yet again? And every 2 weeks, we have a regular MDT between all the stakeholders involving wound healing and a reduction in wound infection, where we look at the results and we try and work out, are we underperforming? Are we improving? Is there things we can change? Next slide, please. And this is the results from the following year, January to March 2017, where we have managed to reduce our wound infection rate, and now we're near the average for national average, but we haven't really looking that good either. So we're average now, but we're better than we were before. Next slide, please. And you can see from the data, which we've submitted quarterly, that the rate is slowly declining, but despite our best efforts of changing all the things we felt made a difference, it hasn't made a dramatic effect. Next slide, please. And obviously there are variations from quarter to quarter, but the effect, despite our really very hard work, hasn't been phenomenally successful. Next slide, please. And then COVID came last year, and we ourselves and Harefield were two institutions in London chosen to carry on with emergency and urgent cardiac surgery. The reason being we had the capacity in intensive care. We did not have an A&E department, and we did not have a trauma center. So therefore, we were not expected to take a high number of COVID cases. So during the COVID period, we took on all the emergencies, essentially from North London, came to Barts. Next slide, please. So as a consequence of that, we had a much increased complexity. We had a high increase in dissections, complex cases, which we felt would certainly have an impact on our infection rate. Next slide, please. Because of COVID, we all had to wear PPE. We all suddenly became self-aware of the person next to us. Have they got COVID? Am I going to catch it? So by default, we had some social distancing. We all put gloves on to touch things or examine patients. We all had masks on. We wore a hat throughout, not just theatre, but on the intensive care and on the wards. We had reduction in the number of cases we were doing, therefore we had fewer personnel within the hospital. And at this stage, we also stopped any relatives coming to the hospital to see the patients. Next slide, please. And maybe as a result of this human factor, we looked at our results yet again during the COVID period. Next slide, please. And you can see that suddenly, even though this is statistically not significant, there appears to be a perception of reduction in wound infections. And this slide is a little bit out of date, but I can tell you the results for March and April show less than 1% wound infection, all comers. Because we're still following PPE and we're still careful with our hands and with our wearing masks in appropriate areas. Next slide, please. So what is the bottom line? We tried really hard through science, education, and changing our practice to reduce our wound infection, which is really too high. And it's not until COVID that we actually managed to get a significant further reduction. Next slide, please. The first thing to say, you cannot blame the patient. You have to realize the patient comes in with an intact skin and we do something to them, which then ends up infected. So we must have a major component in causing this outcome. The one thing that we have realized, obviously certain patients are at higher risk. And if we recognize this, then we should try and optimize our management to reduce the chance of their wounds getting infected. The obvious question is, why don't we say every patient is at high risk? We treat them all the same. Because there's some cost implications in that. Next question, please. Good surgical technique, I think, is paramount. I think if you respect the tissues, if you respect the patient, you minimize the trauma you cause them, you have good approximation of the tissues at the end, and you minimize bleeding, your surgical infection rates will be significantly reduced. Next slide. Through COVID, we have educated ourselves about sterility, aseptic techniques, and how to reduce ourselves getting infected. And by default, this is reflected in our patients not getting infected. As you all know, the incidence of the common flu this year was a lot less than last year. Why? Because we're all isolating, wearing masks, and being careful about spreading any bugs. At the same time, the patients have been educated through the public discussions of COVID, and they're taking more care of themselves, and their relatives take more care of them when they go home. Next slide, please. And obviously, the final thing is good old-fashioned aseptic techniques, going back centuries. Wash your hands. Next. Thank you very much for your attention. I'll be happy to answer any questions.
Thank you very much, Alex. I think we're going to take questions at the end, but you have eloquently set the scene and you got an interesting description of three institutions coming together, the behaviors, the human factors, and the consequences of COVID. Now, no discussion would be on wound infection would be complete without having an expert microbiologist. And I'm delighted that Dr. Satya Das, a consultant medical microbiologist at BARTS, is going to join us and follow on. Thank you, Satya. Satya, you need to unmute yourself, please.
Yeah, if I can have my slides, thank you. Thanks very much. Thanks very much for inviting me to your annual meeting. It's like coming to the lion's den. And I've been asked to really focus more from a microbiological perspective of surgical site infection and cardiac surgery. So next slide. I think one of the very important thing in terms of discussing SSI is definition and classification, because these are important both to patient management and also very important is surveillance. As Alex said, we've been taking part with the voluntary PHA SSI, cardiac surgery SSI surveillance for many years now. So the classification is splitting surgical site infection into superficial incisional surgical site infection involving the skin and the subcutaneous tissue. They account for most of the surgical site infections, about 65%. Then comes the deep incisional surgical site infection with the fascial and the muscle layers, and then the organ and space, which is basically, for example, the sternum and the heart and organs in the mediastinum, which account for about 35%. Obviously, it is the deep and the organ and space which are very troublesome and carries high morbidity, mortality rates compared with the superficial. In majority, what is I think important to recognize, the majority of the deep infections, including the organ and space, are theater-acquired, i.e. occurring as a result of contamination of the surgical wound during the operation. And hence, optimal antibiotic prophylaxis is very, very important in prevention, being one of the most important factors. And many superficial surgical site infection, on the other hand, are probably acquired post-operatively, for example, in the ward or when the patient is discharged home. And here, very important in prevention is wound care and infection control, as Alex Cipollino already alluded to in his talk, especially things like hand washing. Although superficial SSI are not as significant in terms of morbidity mortality-wise compared with the deep and particularly the organ and space infections, it's important to recognize that they're actually a major risk factor for subsequent deep or organ space infections of tracking down from the surface into the deeper layers. Next slide. Well, I've already spoken about superficial, deep, and organ and space, and this is gastrointestinal surgery, I'm afraid. So, next slide. In terms of these next two slides are borrowed from Professor Peter Wilson, who's a consultant microbiologist at University College London Hospital, and done a lot of work in the microbiology of surgical site infection and cardiac surgery. And sort of, so what he I'm not too sure whether it's just his studies or it's an accumulation of other studies as well. Probably the latter, the severe sternal sepsis, meaning the deep surgical site infection and the organ and space, complicate cardiac surgery in about 0.2 to 4.5%. And the rate is higher for minor sternal wound infection or superficial surgical site infection at 4 to 7%. And the highest in the leg wound infection, which is 5 to 13%, which are obviously less serious than sternal wound infection. Next slide. In terms of the microorganisms, and this is, again, I think could well be pre-2000, because looking at the Staph aureus used to be the dominant organism at that time. But unfortunately, there has been a huge shift in the pattern of organism causing SSI or found in SSI. As you can see, from this one, if you put them together, which is things like coliforms like E. coli, Proteus, Klebsiella, Enterobacter, they account for probably more than Staphylococci these days. And Pseudomonas accounts for a good 5 to 10% at least. Next slide. And so, talking about antibiotic prophylaxis, and this is our policies at the Barts Heart Center. It's very pictorial, but it includes a lot of other surgeries. They don't focus on that, but just on the left is the cardiac surgery one. And we give, obviously, up to about 24 hours antibiotic prophylaxis. And the first dose of the antibiotic is probably the most important in many of the studies, and should be given within about 1 hour prior to surgical incision. And in our case, we use once daily, or just a single dose of gentamicin to cover 24 hours against gram-negative organisms, and flucloxacillin for Staphylococci, particularly Staph aureus. Here we use the second dose is given once the patient comes off the bypass surgery. The final dose in intensive care unit. The patient is penicillin allergic, or their MRSA positive in the last year, or we don't know the status, then we try to cover the patient as the patient was MRSA positive. Here, so we provide teicoplanin 2 doses to cover staphylococci, including MRSA, plus gentamicin, a single dose to cover gram-negative organisms. In emergency resternotomy, defined as within the same admission, kind of similar regimen as to the penicillin allergy MRSA in the teicoplanin and aminoglycoside. But here, instead of gentamicin, we give amikacin simply to cover the more resistant gram-negatives, things like the ESBL, coliforms, which about 20% may well be resistant to gentamicin. Next slide. And in terms of if the patient is unfortunate enough to develop surgical site infection, our empiric therapy is the first line we start intravenously with amoxicillin, then switch to oral when the infection is under control. If the penicillin allergic or MRSA positive, then we use vancomycin for the MRSA and ciprofloxacin to cover gram-negatives. But how long do we treat for? This is where that classification is important. Superficial surgical site infection, we treat for 7 to 10 days. The deep infection, deep surgical site infection, 2 to 3 weeks, usually with surgery to remove any pus or necrotic tissue. And similarly for the organ and space infection, like sternal osteomyelitis and mediastinitis, 4 to 6 weeks with surgical intervention, because antibiotic alone in this sort of situation is futile. And just a couple of other things very important to mention is that before you do give antibiotic, please take samples for culture. And the samples you take, not swabs, we've more or less abandoned those about South Central for the last 20 years. Swabs are notoriously bad quality samples and often sample superficially colonizing, contaminating organisms on the surgical wound. So it's really pus and tissues, not swabs. That's also important surveillance point of view. We don't actually do any gram stain on swabs. And obviously the patient is paraxial, take blood cultures. And one other important thing is that in chronic sternal wound infection, and if suppose they would not grown anything, always think about would this be Mycobacterial chimera? So we need to have then tissue sample or pus for mycobacterial culture and DNA detection, as well as histology. And of course, always when then the results comes back, then we adjust the antibiotics accordingly, basically choosing the most narrow spectrum possible so that they don't damage your normal flora and predispose the patient for colonization of resistant organisms, including things like Clostridium difficile and MRSA, which are their own problems. So finally, next slide. Just to show you, it's in a beautiful microbiological way, some of the lovely bugs that we deal with in the laboratory. The first two being Staph aureus, Staphylococci, and then sort of gram-negatives organisms in the second row to the right. There's sort of coliform Pseudomonas on the bottom left of the slide you see. And very rarely we get kind of fungal infection, most of which would be Candida, which you see in the middle, and very, very rarely Aspergillus, which was really bad news. Okay, and thank you very much for your attention. Now, again, at the end, we'll take any questions.
Thank you very much indeed, Satya. Some lovely pictures of Petri dishes and nasty bugs. I'd like to welcome Gianluca Lucchese, who's a consultant cardiac surgeon at Guy's and St. Thomas's, who's been there since 2015. And you've implemented an infection control program in your hospital, and we'll be pleased to hear it. Thank you very much.
Thank you very much, David, for the kind introduction, and many thanks to the organization for the invitation. So the topic of my presentation is health economics of a bundled approach to care, and I'm going to describe our experience at St. Thomas. Next slide, please. This is St. Thomas Hospital, where I've got the privilege to work in the central London. Next slide, please. And these are my disclosure. Next slide, please. So Satya and Alex have already introduced the surgical site infection phenomenon, and I wanted just briefly to highlight how this is a multifactorial phenomenon characterized by many variables, including patient's risk factors, surgical technique, environment, and drugs. Next slide, please. SSI is still accountable for the 16% of the overall burden of healthcare-associated infections. Next slide, please. And zero tolerance, getting it right the first time, are some of the SSI reduction approaches that, if correctly adopted, might lead to a significant reduction of SSI. So we are all familiar with getting it right the first time, which is a national program designed to improve the quality of care within the NHS by reducing unwarranted variations. Next slide, please. And St. Thomas Hospital has been reported in 2018 as the best practice case study. Next slide, please. So in order to ensure a consistent implementation, some organizations introduced voluntary SSI surveillance. However, the lack of resources of some trusts have jeopardized the uptake of robust SSI surveillance in most of the trusts, which means also missing opportunities for improving patients' outcome. Next slide, please. The previous one, please. So in 2007, we realized that the SSI in cardiac surgery at St. Thomas was high compared to the standard, and initially started approaching the problem at a departmental level. Next slide, please. However, we came across some internal issues like lack of communication, inconsistency, lack of knowledge, lack of leadership, and whatever I call tradition. We as a surgeons tend to do sometimes procedures or acts that are not clearly evidence-based, just because we have learned doing them that way and we keep doing it without a robust scientific support. So all these traditions, along with the other issues, have resulted in ineffective interventions. Next slide, please. Therefore, in 2009, we introduced the SSI surveillance as recommended by the Public Health England, in order to quantify the size and the nature of our SSI problem and to direct potential improvement initiatives. Next slide, please. So over 8,000 patients were eligible for analysis. Next slide, please. And our surveillance team, which is made of a team leader supported by 2 co-workers and infection control consultant, has overseen the whole process. Now, I'm going to hand over to Lilian at the end of the presentation in terms of how our surveillance, SSI surveillance is structured, because she's the team leader for this, and I'm sure she can give you significant and more detailed insights on this. So if we can move to the slide number 16. So the intervention supported by the surveillance team were aimed to make several implementation and develop a bundle approach to the problem. So this also based on Department of Health High Impact Intervention and NICE guidelines. Next, please. Interventions were covering all the aspects of the patient's pathway, including prevention, evaluation of the current practice. Next slide, please. And also baseline SSI prevention strategy, with particular regard to the antibiotic prophylaxis and the strict glucose control. Next slide, please. So in 2009, our rate of infection was around 5.5%. Next slide, please. And we started by decluttering and segregating the donor and internal scrub trolleys in theater, along with the standardization of data collection and reporting, and surgical site infection surveillance leadership with defined champions at several levels. Next slide, please. 1 year later, our infection rate had already dropped below 4%. So we kept monitoring surgical wounds for infection leaflets, but also standardized our preoperative preparation, introducing the chlorhexidine cloths for skin decolonization preoperatively, and also introduced the chlorhexidine for skin prepping intraoperatively. Additionally, we provided the patients with some leaflets for preoperative skin decolonization. The patient is eventually the final actor of the SSI, so we felt that involving the patients was of paramount importance. Next slide, please. In 2011, our infection rate had already dropped below 3%. And we kept progressing with further implementations. First of all, we tried to standardize the technique of prepping intraoperatively because there was kind of variation between the consultants, so we made sure that everybody was following the recommended indications. And also another important aspect was covering the exposed skin with sticky sterile draping. Next slide, please. This eventually determined the significant reduction of our SSI rate up to 1%. Next slide, please. Why chlorhexidine? Because already in 2009, some papers started highlighting the superiority of chlorhexidine in comparison to the betadine in terms of SSI prevention in the clean contaminated surgery. And this is one of the first papers published on the New England. Next slide, please. Although cardiac surgery was not mentioned, there was a significant reduction in wound infection in thoracic surgery, which is very, very close by. Next one, please. The data have been further supported, and this is a further review, systematic review and meta-analysis of the advantages of using chlorhexidine in comparison to betadine in the clean contaminated surgery. And again, the literature was definitely in favor of the betadine, so the chlorhexidine. Next slide, please. This has been very well documented in the adult population, and recently, I should say, also in the pediatric population. In fact, some centers, some congenital centers have started using the chlorhexidine for the skin preparation in theater. Next slide, please. So our results also showed that the diabetes was a consistent risk factor for surgical site infection. Next slide, please. And you can see on the table on the left side how we have reduced the amount of patients with SSI from 2009, which were 122 over 3,000 patients, up to 2015, where we had only 27 infections out of over 2,000 patients. Next slide, please. Also, the microorganisms causing infection have changed over the years, and we have demonstrated a significant reduction of SSI infection from MRSA. Next slide, please. Of course, these implementations have contributed to a significant cost saving, and we basically saved almost £200,000 in 2017 compared to our average costs in 2009 and before. Next slide, please. So in conclusion, a multidisciplinary approach strongly led by an SSI surveillance service can certainly determine a significant reduction of SSI. and we have now reached a rate of infection which is below the national average. Next slide, please. Of course, the measures have to be evidence-based, and in terms of locally agreed approaches, we have changed over the years. The following: introduction of chlorhexidine in the skin preparation in theater and skin decolonization before the operation. Comprehensive patient's information, because the patients, as I said, needs to be fully informed in order to make sure he follows the right indication in preparation to the operation. Effective feedback of SSI data to the clinical team, because the clinical team needs to know what they are doing wrong. And also identification of local champions in each environment at the consultant level, nursing level, theater level, because of course each professional is able to speak which is equivalent professional in the right way. Next slide, please. So the key of this approach was, in our experience, a multidisciplinary collaboration. Thank you very much. Lilian, over to you for the details of our surveillance team.
My apologies for the IT glitches earlier. So my name is Lilian. I lead the surgical site infection surveillance team at Kaiser St. Thomas's. So picking up from where Gianluca has left, I'm going through how we collect our data. So initially, from 2009, we used surveillance forms which were standardized in line with Public Health England protocols to collect the data that we needed to analyze for our surveillance. We supported our clinical staff to collect this data, so it wasn't the SSI team who were actually filling in the forms. And as Gianluca has already highlighted, part of our work was to empower clinical teams by undertaking several presentations at different fora. So everyone was aware of how the data was supposed to be collected and why it was being collected. Myself, as the team leader, was being supported by two junior staff and an ID consultant. We used paper surveillance forms until about 2014, when we piloted electronic wound documentation. Next slide, please. For all the potential and infections that we identified, I attempted to visit clinical areas to speak to the patients and also to staff who were looking after those patients and review the paper documentation and any electronic documentation that was available to identify evidence of surgical site infections. And as Gianluca highlighted, it was important for us to standardize the way this information was being collected to make it easy for us to fulfill PHE criteria for those patients who had confirmed infections. We fed back our data to clinical teams monthly, as well as publishing anonymized data on our trust intranet. So all staff had access to all the SSI reports for areas that we're undertaking surveillance, including cardiac surgery. Next slide, please. So we have continued this process, and we really feel that by continuing to support our local champions and all the clinical teams, we have managed to introduce measures that has led to significant reductions in our SSI incidences, as you have seen that being presented by Gianluca. So as of now, we continue with our prospective data collection. It's still being coordinated by myself as the team leader, but we have also managed to now hire a qualified nurse to work with myself and one support worker as we have continued to expand this program over the years. From 2018, we introduced electronic surgical wound documentation, which enabled us to actually even standardize further the way the data was collected, but also it being available in an electronic format. It meant that different clinical teams could access the data at any time, and we could also use that data to review interventions in a more straightforward manner than we had done before. We undertake SSI investigations for all the patients we identify with surgical site infections and identify any themes or learning that we can use to improve practice. And so I really feel that there being a surveillance team in place who were persistent in promoting this program in the organization, we have really managed to improve our surgical patient outcomes in adult cardiac surgery and other specialties as well. So that will be it for me. Thank you very much.
Lillian, thank you very much indeed. And thank you very much to our speakers for generating a lot of thoughts and ideas. What strikes me listening to you is that, one, there are a lot of human factors involved: communication, education, and leadership. We need to actually have a standardized performer for looking at wound infections. And we'll come on to the questions. And so the first question I have here is, what in diabetic patients, what HbA1c are you looking for in preoperative glucose control, Alex and Gianluca?
If I may start, we realize that obviously we have quite a high population of diabetic patients where in our catchment area, their diabetic control is quite commonly poor. And if they're elective cases, we tend to, during pre-assessment, we pick this up and we get them in contact with the diabetic nurses locally or in our hospital to resolve their diabetic control before they come to theatre. And obviously when they come in, we have a very strict diabetic regime to maintain normal glucose.
And what do you think, Alex, then has been the biggest game changer in BARTS over the past 5 years?
The incremental changes for the last 5 years have been lots of community discussions, looking at small points which we changed and improved, looking at the skin preps, the antibiotics, things. But to be honest with you, the biggest thing we've seen is during the COVID era, when suddenly we expected a much higher increase in wound inspection. We followed our SSI protocols and risk calculators. And in fact, we had a dramatic drop because we're all careful now of spreading infection.
But since most wound infections occur from the patient's skin at the time of operation, is that because you've got reduced traffic in theatre? Or how can you explain that? Or
Yes.
People washing hands better?
We have got reduced traffic, so we reduce the number of people allowed to enter theatres. Medical students which should come in and out before now were stopped for the time period. We stopped the patients' relatives coming in. And because during the COVID phase, we were doing less surgery in total, there were fewer people. The footfall was less in the hospital, so there were fewer people milling around.
So perhaps even better discipline in theatre with less traffic.
It seems to have made a difference, yes. But it's multifactorial.
I'm delighted, putting a hat on, being the director of the Faculty of Surgical Trainers, you're talking about surgical technique. When it comes to closing time, it's often felt coffee time, leave theatre and leave the most junior person to close. What are your thoughts?
Well, we have our SEPs, and because they look after the wound clinic, and they're the ones who usually end up closing the final layers, we really focus on them, support them, and help them to make sure it's a really nice, watertight skin closure. Because if it isn't, the patient gets a wound complication, they look after the system. So
what do you mean by watertight? I was intrigued to use that phrase.
Well, the skin, I'm a firm believer the skin closure has a good approximation. If you have gaps where you have fluid leaking out and potentially bacteria entering into the wound, you're opening yourself to a high infection.
And I was just wondering, Alex, how do you open the deep tissues to the sternum? Do you use a knife or do you use diathermy?
I use a knife.
You use a knife?
I do. I want
Yes.
to devascularizing the tissue.
Yes, and there's a paper that came out in Midwest America where a surgeon halved his wound infection rate because he used knife only to the sternum.
It also depends how you use the diathermy.
Yes. By definition, that'll fulgurate the tissues anyway.
Yes.
But I'm very interested, again, Lillian, that you lead your infection control surveillance. Can you describe how you score or grade the wounds?
So what we have done as an organization is to design standardized surveillance forms, which enable us to capture information that will then fulfill PHE criteria for a surgical site infection. So on those forms, staff are recording and telling us whether there is heat, redness, swelling, pus, and all the other objective criteria. So when that's being completed, we then educate our staff as well on PHE criteria for what a superficial infection is, deep in organ space, and then they can make reference to that and tell us what they think from the electronic documentation. However, as the SSI surveillance team, we then validate that information and scrutinize it until we identify patients who actually fulfill SSI criteria, and we record and feed that data back to the clinical teams.
So you've got your own bespoke design record system.
Yes, we do. It's all standardized, so everyone is doing exactly the same. And again, I think
that's in your hospital. Yes.
Yeah.
But I'm just thinking from Alex, from a national point of view, to address this issue, we don't appear to actually have a standardized recording system to look at wounds.
We don't. And the thing we found in our institution, and Satya can back me up on this, is that we first of all, we need to identify and classify the infection, the wounds, which we find it quite difficult. Is it deep, superficial, yes or no? And part of the PHE information you need to send back is patient-reported wound infection. And as you know, commonly a patient will go to the GP with a slightly red wound, which is just a healing process, and they'll be given a course of antibiotics. And also that flagged as a wound infection.
So this is interesting because you're talking about classifying wound infections and things, but any wound problem is a problem to the patient, where there's a little ooze, a bit of discomfort. Maybe we should turn the question around and actually just score the perfect wounds only.
That may be a way to deal with this issue. I think.
So because I've sat in meetings and people said, well, that wasn't quite a wound. So Satya, you could talked about classification. They said, well, it wasn't really a wound infection, was a little bit oozy, but was culture negative, or was a bit red, but that's not an infection, or that was superficial only, that's still not an infection. And I've heard these discussions at meetings as people seem to pass the buck, and there seems to be a stigma attached to a wound infection. And maybe we should turn around. In the same way we report survival. Satya, your thoughts. Why do we have to classify them?
Yeah, absolutely. I think this is a very important point because otherwise you speak to 20 surgeons, you get 20 different answers.
Yes.
One of the most important things is standardization.
Yes.
That is obviously even more important for surveillance. And in this, the PHE has done a very good job. Actual definition didn't come from the PHE, it came from the CDC in 1992 when they defined, said these are the definitions, surgical site infections. These are the criteria. And these have been amended both by CDC and the PHE. But it's important also internationally, globally, because Otherwise, how do you compare risks across countries?
Exactly.
And so it was very important that is not, and these definitions, although they're meant for surveillance, they can be used for individual patient diagnosis and management. Because I think we need to do that properly and comply with it. Otherwise, we'll get all different answers.
Well, that's why I'd like to see us change the question, because I think until we have standardized definitions, there will be arguments. And you just alluded to 20 answers to one question. But going back to what I said before, you can't deny a perfect wound. So the other question is, how do we actually, some wounds, people go home with healthy wounds. How do we actually record or capture what happens? You got a wound clinic, Alex, at Barts. How do we capture that late wound problem and late wound infection?
Well, our wound clinic has slightly evolved in the COVID times, because now we do a virtual wound clinic. So we take pictures of our patients' wounds before they leave, and they're given a copy of that.
Yes.
Changes, they're encouraged to take a photograph themselves, or someone do it for them, which they can send to an email address, and someone will look at it, bring them back and discuss.
So there's an opportunity, maybe, using mobile technology to extend the wound surveillance to enable the patient.
There is, yes.
Yes, that would be interesting. That would be very interesting. So, Jen, looking at your bundle, and all of you have presented pre-op, op, and post-op, and I recall patients being sent to go and have a bath the night before surgery, hopefully chlorhexidine, but they go in there and sit in the room and actually smoke a cigarette. How do we actually get the patients engaged in taking this seriously?
But this is why we worked also on patient information, not only providing them with booklets, but also having a nurse looking after their shower before the operation and so on. It's not only matter that patients underestimated the importance of wound infection because they have never been through a wound infection, so they don't know what we are talking about. But also sometimes it might be a matter of education. They are not all well educated, let's say, so the comprehension of the problem might be different. We worked quite a lot on centralizing the patients because, of course, they will be the final actor of this problem eventually. And I think a wound infection, so as a neurologic complication, change completely the patient's experience after a cardiac operation, irrespective of a full sternotomy approach or minimally invasive approaches, because we shouldn't forget that also the groin incision in people that do perform a minimally invasive surgery might get infected, and then the patient needs constant review of that groin wound. So he has recovered excellently from his chest operation, but still for months he needs to go to the wound clinic to review that groin infection. So it's a complex problem, and the patient needs to understand this very well, because it's almost, and from my point of view, in terms of affection of his quality of life, worse than major complication.
Alex, did you see a significant reduction in wound infection with the advent of endovascular vein harvesting?
Yes. Yes, our leg wound infection is about 8 to 9%, and then it's down to less than 1% now.
And that is again done by the surgical practitioners. Yeah. Okay. Now, the original SSI bundle, and what is common in America now, is no patient should leave theatre without a warming blanket. Do you have any guidance on temperature and bypass temperature and leaving theatre? Because temperature is included in the SSI bundle, but cardiac surgery was excluded because we've often used hypothermia as one of our tools.
Yeah.
The one thing we found on a slightly separate issue, we looked at bleeding rates and the temperature of the patient in the ITU. They go back cold, they bleed more.
Yes.
So we made all the effort possible to try and rewarm the patient adequately in theatre and have a bear hugger available when they go back to the unit to keep them warm. again, through maybe not selling it well enough, it's not a universally taken on board, and it's the variability in outcomes. But I take your point. I think the patient is dry and warm, they do better.
And you, Alex, had 3 different institutions come together with 3 different ways of doing things. Gianluca, you've actually, Lillian has actually said that as surgeons, we talk, and one of the biggest sins is because that's the way we've always done it around here. Do you not think that we could not agree a standard operating protocol on how to open and close the chest based on best evidence? And if that's the case, how do you think you can get 365 cardiac surgeons in the Society of Cardiothoracic Surgeons to do it that way?
No one's going to agree, David. You know how we are. We don't listen to anyone else. We think we're the best. We're no better than anyone else. And the only way you can do this, and we try this at Barts, where you publish the outcomes of wound infections with names next.
That's the SSI bundle that I talked about at the beginning, surgeon-specific infection data.
Tell us what happened.
Yeah.
The outrage and the bits of paper being ripped off the wall. Smells that kept flying around. It was very difficult to continue with that.
But going back to my story on positive deviance, I would be intrigued to know who had all wound problem at 0, and I'd be very keen to learn what they do. So Lillian, you've led your infection control program at Guy's. How are you finding it, marshalling all these people and getting them to follow the standards? You can speak honestly.
Yes. So to be honest, I was very fortunate, especially for cardiac surgery, that I came across very enthusiastic consultants. Gianluca is here, of course, and Miss Blau is the one who actually initiated this when I joined, and he sort of just said to me, just get on with it, and if anyone gives you any problems, come back to me. So I think everyone was very keen to make a difference, and really the focus on patient safety, I think, then got to those who really wanted to engage, because you may be a professor in surgery, you may be a surgeon who's been operating for years, and I may just be a nurse, but what we all want is for that patient to have safe surgery. So I think once we had that common ground, of putting the patient at the center of everything we did, I didn't have any problems with anyone, and even up to now, I've got people wanting to do this, and certainly feeding back the data also was important, and providing surgeon specific SSI details helped other consultants to come on board. And I also had the opportunity to meet one-to-one with some of the consultants who had slightly higher risk than others, and we just had a good conversation over a cup of tea, not really kind of blaming, but kind of saying, this is where we are. Can you help us to improve the patient's journey? And yeah, it's been fantastic, and really enjoy, working with all you lovely surgeons.
Lillian, I think you've eloquently summed that up very well, because at the end of all of this, no matter what level you are, we're dealing with patients. And I'll go back to the introduction. I think the mortality from elective surgery at the present moment is absolutely fantastic. Next mountain that we need to climb as surgeons and as a society is that we need to stand up together, adopt a standard operating protocol, look for the best, find the best, and deliver the best for our patients. I'd like to thank the panel who's joined us this evening. I'd really like to thank our sponsors, BD, who are world leaders in wound infection and bring together international communities to discuss this ongoing problem. But together, we can reduce it. Thank you very much indeed for joining this seminar. Thank you very much to the panel. Very kind of you to join us. Wish you well. Wish you good evening. And please stay safe. For those people in India, in Chile, We are thinking of you in this time of crisis with COVID. Good night, good day, good afternoon, wherever you are. Thank you very much.
Thank you.
Thank you.